Okay. All right, everyone. Happy Tuesday. Thank you all for being here and joining us again for another office hour session from the California Telehealth Resource Center. We're excited to have another telehealth talk with everyone. In today's session, we're excited to bring Christian Milaster, the founder and CEO of Ingenium Digital Health Advisors, for a really awesome session. Today, we're going to be talking about the future is virtual care, but how do we get there sustainably? Thanks. A few tips for everyone on Zoom. You have been muted, but we do encourage you to join us. We're casual, we're hanging out. Please turn on your camera so we can see your faces as we go through the content in this session. It's really helpful if we can see your face a little bit. We're also going to encourage you to use the chat. If you have comments, if you have questions, you want to talk more about something, please let us know all your questions. We will have some time for Christian to answer some questions, and then us from the CTRC, we're here as well. So please chat with us as much as you like. Another reminder that today's session is being recorded. So if you need to hop off or you want to revisit any of the stuff we're going to talk about today, we will have this session posted to our YouTube and on our website by the end of the week. Glad to see some faces. One last reminder, as always, for our sessions, CTRC does not provide any legal advice. Anything that we share today, there's no relevant financial arrangement, affiliation, or interest with any products or services that may be mentioned or discussed. Everything is just for informational purposes. So we are supported by our grant. And that is all. From here, I'm going to introduce our wonderful speaker for today, Christian, and hand it over to him. Last reminder, turn on your cameras, folks. Join us.
Please turn on your cameras. Yes, it's much nicer. And if we were in a meeting room, you wouldn't be hiding behind a magazine. So if you can, please unmute your cameras. Anything else, Aislinn, or should I just jump in right ahead?
Yeah, it's all yours. Go ahead.
Okay, good. And just a little more, one more housekeeping. I actually have two screens here. So if I'm looking here, I'm checking if you're turning on your cameras. And I actually may move my camera over there. So I appreciate you turning on your camera so it's a little bit more live. Actually, I will do this right now. So I'm looking at here. I'm looking at your beautiful images. Hey, John, nice, good to see you. Thanks for joining. Thanks, everybody, for your interest. And yes, as Aislinn was saying, I'm very happy to entertain some questions here. I'm having some time for Q&A here towards the end of the hour, and then I'll wrap up with a few more questions, but please post your comments and questions in the chat here. I've got it up on the screen, and let's get going. A lot of content here today. Exciting topic. Telehealth is here to stay. I stood at a sister organization of the Caltrac, the MATRIC, the Mid-Atlantic Telehealth Resource Center, on the stage in 2014, singing, "It's very clear, telehealth is here to stay." It was a one-time experience only, so I'm not going to sing again. But here we are 9 years later, and it's true. Telehealth is definitely here to stay, but how can we make it here to stay sustainably? Some organizations are succeeding very well. Some organizations are struggling. We work a lot with the organizations that are struggling, that are finding some resistance in the clinicians. And so I'll talk about all these things. I'm going to get started here with an overview of the agenda with of what we're going to be covering today. So I'm going to leave you first in the very first minutes with a telehealth sustainability recipe. Then we dive into defining telehealth, which by now everybody has kind of a similar definition. And then there's three areas that I really want to look into. I want to look into financial sustainability. I want to look at clinical sustainability, as well as strategic sustainability in the organization with kind of like a roadmap of activities. Good. I see my internet connection is unstable, so Aislinn, text me if that gets too bad. So hopefully, but it'll stay here. So I want to start first learning about who's in the audience here. We'll then look at the results. So who do you currently represent? Are you a healthcare provider, academic medical center, FQHC, behavioral health, medical consultant, and other? And if you select other, just post in the chat maybe who you are. Again, allows me to kind of tailor my conference. I'm talking mostly to rural and smaller healthcare organizations. I'm talking to larger academic medical centers, so community health worker. Thank you. That's yeah, CHWs are going to be the backbone of future telehealth delivery and implementation. Very good. OT clinic, yes. Occupational therapy is definitely getting into it as well. Good. I'm going to answer the poll as well, so there we go. All right, when we get to about 60% participation, we can close the poll and show the results. FQHC, very good, yes. We're working with a lot of FQHCs. All right, we've got some answers here. Good 30%, got 50% providers. Very good. We've got some consultants and others. Very great. Thank you for posting your roles in the chat as well. County-based community paramedic, yes, also a key integral part into establishing telehealth. Wonderful. Thank you so very much. A little bit about me. Just Chris Milaster, born, raised, and educated in Germany. Started my career in software development and software engineering, and then I came to the US 25 years ago. Stumbled into healthcare at the Mayo Clinic, fell in love with healthcare, and then in 2012 had an opportunity to launch my own consulting firm, focusing on implementation of telehealth and digital health solutions, mostly in the recent 5 years in rural healthcare organizations, FQHCs, smaller behavioral health clinics. And so really love being at that intersection of technology and care delivery, and ultimately enabling the delivery of extraordinary care, helping clinicians to really focus on care delivery with the use of technologies and great workflows. And that's really the theme that you'll see throughout the presentation. So that's about me. Okay, so let's start with the kind of the key giveaway here, the key takeaway at the very beginning, so that if you need to have another meeting at the bottom of the hour, you at least walk away with some value right away. As I mentioned before, we're going to be focusing on the clinical sustainability of healthcare, because ultimately it's about a patient care delivery. We focus also on the strategic sustainability, making sure that telehealth supports the strategy of the overall strategy of the organization. And then, of course, we can't do this without getting paid, getting reimbursed for telehealth. So we need to also address financial sustainability. But it's really through these three lenses that you need to look at long-term telehealth sustainability in traditional healthcare organizations, meaning the traditional health systems, FQHCs, behavioral health, versus like the Teladocs and the Amwells, their new breed of healthcare delivery organizations. So here's the 3x3 recipe that I would prescribe, or could be also considered a prescription. The first level is you have to have executive and clinical leadership engagement. No sustainability will be achieved unless you have the executive leadership on board and unless you have the clinical leadership on board. The next part is we need to have clinician engagement. We really need to make sure that clinicians feel comfortable doing video visits, that they feel comfortable prescribing our remote physiological monitoring, or in the very near future, if it's not already happening, actually providing digital therapeutics, right? So we're moving from telehealth really very swiftly here into the whole digital health realm. And so this is not just a one-time exercise about telehealth. This is really about integrating digital health solutions into care delivery. And then the third prescription is what I call 100% telehealth mindset. And I explain what that means a couple times here during the presentation. So for executive and clinical leadership engagement, you really need to have a strategy to find why are we in telehealth, why are we doing telehealth, how are we doing telehealth, how are we growing it, how we're optimizing it, how we're expanding it. That's what a strategy needs to lay out. In order to do that, you need to establish a multidisciplinary governance team. And then we need to go into performance optimizations. You can't manage what you don't measure, so we have to measure the performance and continuously optimize it. So those are the three ingredients to telehealth sustainability on that leadership portion. For clinician engagements, we need to really have optimized workflows. A lot of the telehealth workflows, the video visit workflows, are not optimized for the clinicians, which is why a lot of clinicians were very frustrated during COVID when they got thrown into telehealth on an ad hoc manner. We need to provide some training, and it's very minimal. It's just kind of less than 90 minutes, and I'll explain kind of what training we recommend and we advise and deliver. And you got to support the clinicians if there's any problems, because they got to focus on the patient care delivery. And then what does 100% telehealth mindset means? It means that we should be doing telehealth every time when it's clinically appropriate, when the patient desires it, and when the patient has the technical capabilities to do that. That is really the gold standard. And so that's if that mindset is anchored in the clinical community, with the nurses, with the schedulers, with the front office staff, that is really the attitude. It's like, yeah, if a patient wants telehealth and they can do it and it's clinically appropriate, we should be doing telehealth. Why wouldn't we, right? Because it is a very convenient and accessible way to deliver care with a lot of benefits. So that's the 3x3 recipe. I'll come back to that at the very end, but that is basically what we'll be covering here today. So starting with the definition, everybody agreed until somebody defined it. I learned this lesson after way too many committee meetings at the Mayo Clinic, so large academic medical center, we're rehashing. So here are our pragmatic definitions of telehealth and telemedicine, which I use interchangeably also with virtual care. Telehealth is delivering care at a distance. It's really anything that we do as an organization to deliver care. That includes scheduling visits or downloading immunization records or refilling your medication or whatever it is. Everything has to do with delivering care is at a distance is telehealth, and then telemedicine is practicing medicine at a distance. These are the interactions between clinicians and patients, either synchronously or asynchronously. And COVID really introduced, or the media really introduced this term virtual care, which I kind of like better than telehealth, because it's about care delivery and it's just being done virtually, basically at a distance as well. So that's the definition, but I use these three terms mostly interchangeably. But it's important to note that the telehealth really breaks down, or virtual care really breaks down into different modalities. There's telemedicine, there's remote physiological monitoring here and at the bottom center. There's interactive patient care, which can be video visits, which can be asynchronous messaging. And there's the traditional store and forward. So faxing an EKG in the 1950s was already telemedicine. And so every time we provide care at a distance, or diagnostic services like teleradiology really took off in 1995, and virtually every radiological read is done remotely these days. Very few organizations still employ radiologists on staff to read. So that's really the evolution. But then it also includes like teleeducation, patient portal. I know there's a lot of push, especially in FQHC organizations, towards a patient portal to have a digital front door. But all of that still falls, by our definition, under this umbrella of virtual care, or previously known as telehealth. Another way to look at telehealth is also that there's 9 common virtual care modalities, but the one that we all know and love are audio, video, televisits, video visits. During COVID, a lot of telehealth was actually just telephonic care, but also telephonic care has been around for a long time, not been reimbursed, and is still not reimbursed at the same rate. And again, depending on the circumstances, it may also not be the same kind of quality of service. When we get to a value-based environment, which I'll also talk about a little bit in the financial sustainability section, we'll see that telephonic care can actually be a key ingredient also to improving health outcomes. And then the more complex axis here, so I'm going through this 2x2 matrix here, from simple to more complex, from synchronous to asynchronous. If we add exam capabilities, like doing remote exams in elementary schools, if you have school-based telemedicine, or if you have a clinic-to-clinic setup where you can do an exam where you at least capture some vital signs or do some live examinations of like remote dental exams, those are all possibilities, but a little bit more complex. Then we have the whole world of periodic remote physiological monitoring, like weight, blood pressure, glucose. Some of it can be done continuously, like with a continuous glucose monitor, or even continuous heart rhythm monitors. And then there's the whole world that we really haven't explored yet of patient-generated health data with our Apple Watches, with our Fitbits, with our phones, right? Giving physicians access to this data would be really valuable, but it's complex and complicated right now to get access to this data. Then we have the store and forward of photos, audio, video data. And secure texting, secure messaging, right? I think that is really the up-and-coming service, because this is how we communicate with family and friends. I mean, for the last 15 years, we really shifted into texting. I don't know, I'd rather text somebody with a quick message than pick up the phone and call them, because it's more convenient. And so this is also then how we want to receive our care, being able to ask a question and a few hours later get an answer, right? We don't need instant response, so it can be asynchronous. But it's very simple to implement in a secure way. Reimbursement, again, any clinician will just raise the hand immediately, say, well, yeah, but we don't get paid for that time, and it can get out of control and out of hand. And so there needs to be things established. The last one here is digital therapeutics, right? That's the one I mentioned earlier. The prescription of apps for treatment, like in Germany, where I'm originally from. There's now 2 or 3 apps, one of them for tinnitus treatment, that are being reimbursed and or being paid for by the insurance companies, and even the providers get a little nominal amount when they prescribe this particular treatment. So that is up and coming as well. Needs to be obviously clinically validated, but so telehealth, getting familiar with digital tools and digital technology is really important to make telehealth sustainable, and then also to improve care delivery in general with the digital health tools. Good. All right. One more way to look at it. I'm an engineer. I love numbers and I love permutations, if you haven't figured that one out. So 3x3s and 4x4s. So here's 96 different video telemedicine scenarios. And it's like, 96? How is Christian going to come up with 96 scenarios? Well, it depends on where the patient can be, right? The patient in the traditional history has been in the clinic or inpatient, right? We had 2 scenarios. Then we added work or school locations to it. And now patients can be at home or they can be traveling. We can also do all of these 3 just as video visits or with a virtual exam, right? So there's a number of scenarios already. Where can the clinician be? Well, the clinician can be in the traditional environment in a hybrid clinic. They're doing in-person visits and then they switch to video visits, or it's interspersed, or maybe it's on block in an afternoon. They can be just sitting at home and doing just telehealth after telehealth after telehealth. If you're an employee of Amwell or of Teladoc or Specialists on Call or Equum, right, that's what you do. So you do just sit in your office and you do care virtually all the time. They can be at home, like even if you're employed, but you're maternity leave or COVID leave. So you just go and you work from home, or you can even be traveling, like me. I'm actually in Mexico right now, and I'm just delivering my speech with my virtual background. And if I were to provide clinical care, which I won't, then nobody would even know the difference whether that I'm in Maryland or wherever I should be. So that gives us all these different scenarios here. And let me add another dimension to it in case you started doing the math. It also, the workflow, the scenario, which is what I'm leading up to, also depends on the nature of the visit. Most of our visits we think about are planned, are pre-scheduled in our calendar, but a lot of our care needs to also be like urgent care or ad hoc. I work a lot with FQHCs, and we have a number of calls coming in every morning and say, I need to see the clinician and I need to see my physician. And so that's where unplanned same day, and then unplanned immediate, and that needs to be seen. I mean, not 911, but like an urgent care visit. So there's different scenarios. So let's do the math, right? We have 5 permutations up here, 5 locations for the patient, times 4 locations for the provider. It's 5 times 4, and then we add these 3 times 4, that's 32, and we multiply that by 3, so we get to 96. Why is this important? It's important because every one of those different scenarios requires a different set of technologies, a different set of workflows, how you schedule it, how you room a patient, what you do after the patient, after the visit is done. All of these have a lot of things in common, but also very much in a nuanced way. And so we need to really be more conscious about how we design all these different workflows, or just it also illustrates how much telehealth is actually possible that wasn't possible when we're just thinking of a brick and mortar in-person environment. And so that's really the point of this slide, a little bit tongue-in-cheek, so, but love it. All right, so let's talk money, let's talk financial sustainability. So let's start for fee-for-service reimbursement. Again, I'm not a lawyer. I'm not a financial telehealth reimbursement expert, but this is what I've learned. This is what I've observed over the last 15 years that I've been in it. Um, all is actually pretty well, and has been even before COVID, with one exception of the location of a patient for Medicare telehealth reimbursement. But everything else was even before COVID moving into the right direction. We now have, at least according to my last count, parity in 43 different states. That's payment parity actually in 26 states, meaning that if an insurance company would pay for an in-person visit, they also have to pay for the video visit at the same rate, at payment parity. And then there's service or coverage parity in 17 states. And so that is really already for commercial insurance and reimbursement is there. And a lot of insurance companies, especially in the wake of COVID, saw the benefit of reimbursement for telehealth, seeing it as an equal to in-person care as well. The state Medicaid programs, to my knowledge, most states reimburse for video visits and RPM. It's been going on for a long time. I'm not going to dive into the 50 different programs here. And in Medicare, a lot of reimbursement prior to COVID, as I mentioned, and COVID removed that patient location restrictions. And there's a continued addition of additional services, additional clinical professions and specialty services. So everybody is really moving into the direction. There's one caveat, though, and we have some FQHC members in the audience. So what I call them the forgotten, and it's the rural health clinics and the FQHCs that are currently, they don't have payment parity. They're getting paid at a much lower rate, at around a little bit under $100, which is very different than what a rural health clinic or an FQHC gets as the standard rate for reimbursement. And so there's some hesitation about offering or going all in with telehealth. Now, it's better to have a telehealth visit financially and for the patient than to have no visit at all. So we need to look at it that way as well. But definitely, this is something that needs to be addressed by Congress and or by lobbying. So this is definitely something that is unfair in my opinion, because I don't see any reason why everywhere else gets paid parity, but in the FQHC and the RHC world are not. And we're working currently with a lot of those organizations. And many of the COVID exemptions set to expire in December 2024. So again, we gotta have Congress put some of those exemptions into law. So just need to round this up. So this is not here to stay. Or some of the exemptions, like for FQHCs and also some Medicare exemptions, are not set in law yet. But we all expect here in the community that that will be the case eventually when Congress literally and figuratively gets their act together and makes those changes. Good. So that's my view of the fee-for-service world. So definitely, if any CFO says, "Well, I want to invest in telehealth because I don't know if reimbursement is here to stay," this is a starting point for a slide, and then send them over to the Center for Connected Care Health Policy, or I always got the name wrong. That's also under the same grant as the telehealth resource centers. They have great information about every state available on Medicare, Medicaid, and commercial insurances. So a treasure trove of good information, up-to-date information. But here's another list of 9 items that you can do for telehealth to improve the bottom line of your clinic, of your hospital, of your health system, of your FQHC. You can fill provider schedule slots with virtual visits, convert cancellation and no-shows, for example, into video visits. You can expand into new geographic areas that are underserved, that previously were maybe not that reachable. You can now offer access to new specialties. You can bring on some rheumatologist or pediatric cardiologist, give them access to it, make them part of your care team. You can compete against what I call the convenience competition, right? The MWELs or the insurance companies are saying, don't go to the doctor, just use this video service that provides really great fragmented care where there's no continuity of the medical record, but it's cheaper for us, so please do it. Sorry if any insurance people in the audience here, right? But it's as a health system, we value having continuity of care and having a continuous medical record, so clinicians can see the history of the information provided. And so I call that the convenience competition. Improve retention with the existing staff by offering telehealth options as a flexibility, or accelerate recruitment through virtual-only providers. One provider, behavioral health provider, left the Finger Lakes region, moved to Detroit, and they couldn't find a replacement, so they just could just continue to employ that person through that. So examples galore as to where people found it a good solution to be a telehealth provider. And then hospitals reducing readmissions, a slam dunk scenario for remote physiological monitoring for 30 days, maybe 45, 60 days, really getting the patient stabilized. That is an easy decision for any virtual hospital, even if your readmission rate is really, really low. Just one readmission safe will pay for the whole program investment. And then, as I've mentioned a couple of times here, value-based improvements, really looking at, in a value-based environment, to really leverage telehealth to improve health out. So let me bring back a few of those 9 modalities that I showed before. But before I do that, let me actually get to the point of kind of patient engagement and patient activation. This is a little kind of research or just analysis that I've done a few months ago, where I really thought, it's really interesting how we treated our patients here over the last, let's say, 30 years, right? At the beginning, it was all about compliance, right? The providers are the gods in the white lab coats, and they will tell you what to do, and you need to take your medication, and you need to do your exercise, and if you don't, then you're not compliant. And so that was a very interesting adverse relationship between providers and clinicians. Then the language was a little bit softened, adherence, so it's sticking to a plan or regimen. So at least there was an idea, there was a plan that was developed, hopefully jointly. But then the real shift came, I would say, about 15 years ago, when everybody started talking, no, we need to engage patient in their care. We need to really enroll them, involve them. They need to participate in the decision-making process, right? We cannot just dictate from the top what patients should be doing about their life. And then hope that 3 months later, when they come back, they've done everything that we've told them. So that realization kicked in. And then the latest term that I really like is that if clinicians take on the responsibility, it is my job to activate the patient to play an active part in their care, right? That shifts really the mindset. And so, and that will also help to make telehealth here to stay, because in order to activate the patients, what do we need? As humans, we want to belong, we want to be cared for, we want to be communicated with. And so being in frequent communication is really great. Now, in the fee-for-service environment, that is not possible, because we can't even we can't talk to a patient twice and get paid twice in the same day, sometimes not even the same week, right? There's limitations on that. But if we switch to virtual care modalities like secure messages and phone calls and video visits to really take care, just checking, hey, just the 3-minute phone call, just wondering how you're doing, or a secure message, hey, you got any questions? I think I saw you picked up prescriptions, and right. So anything that can be done to create this impression that, hey, we're watching you, we're taking care of you. A lot of the implementations for remote physiological monitoring that we've done, the patients report said, it's so nice that I know that when I take my blood pressure, somebody's going to look at it a few hours later. And if something is off, somebody's going to give me a call, right? They don't feel alone with their health conditions anymore, and they're activated. But it's the human component. No technology can facilitate it, but it cannot replace it. It can augment it, can aid it. But this is really what we should be using technology for. Same then with remote physiological monitoring, leveraging more of the patient-generated health data, and then also if patients have any records of their health, taking a photo of a lesion or anything, having that ability, again, in a value-based care environment where we just care about outcomes and reduce utilization of the ER or urgent care or admissions, we can do whatever it takes in order to make sure the patients stay actively engaged in the care, especially if we're managing chronic diseases. And then ultimately, we can also start prescribing digital therapeutics, not worrying about whether we get paid for it, but we're worrying about, is this the right tool for this particular patient to make sure that their health is well managed? So really, I'm hoping that still in my lifetime, I will see that shift to value-based care really being used predominantly in the care environment. Good. So that was about the financial sustainability. Let me now switch to the clinical sustainability. Obviously, nothing works without the clinician buy-in, without the providers feeling comfortable of doing telehealth virtual care or using RPM and interpreting the data. And so really the mindset that needs to be promoted by clinical leadership and become prevalent among the clinician community is that telehealth is a clinical tool that you as a provider have in your hands to decide what is the best care delivery modality to give your patient the best access to care, like we had on the previous slide, right? Is it a secure message? Is it a video call? Is it RPM? Is it digital therapeutics? What is the best way to help you to manage your health well, to get well and to stay well? Most clinicians, by my observation, have never been formally trained in creating a great virtual presence and or conducting virtual physical exams. I think we have a chief clinical officer who worked at the Cleveland Clinic for 20 years, 15 years of which he managed virtual care, urgent virtual care there. And he does our virtual physical exam training for clinicians. So that is something that clinicians have not done in their medical training, are probably still not getting yet in 2023 in their medical training. Yet it only takes 20, 30 minutes to really educate clinicians on how to do this well. They are concerned, like any of us, that they'll look stupid if something were not to work, which is exacerbated in the clinical environment because the approach to healthcare is that you want to be confident in your diagnosis, you want to be confident in your decisions of treatment, and so anything that takes away from that experience that makes physicians and other clinicians feel like a fish out of water, and that's uncomfortable, and then they're rather not do it because and they've had bad experiences with COVID, with technology, with videos not working. So they've tried it, and so it's kind of a bad experience. And what most clinicians also not have done is they have not sat down and have said, okay, when is telehealth actually appropriate, right? They say, oh, telehealth doesn't work, or my patients don't want it, or we don't have the connectivity, or all kinds of excuses or explanations for it. But actually sitting down, we're facilitating that with our clients, is like sitting down and identifying the criteria for which like an ad hoc or same day clinical visit is appropriate to be offered as telehealth, right? Just understanding, just going through the scenarios. And there's some for which it's not appropriate. So 100% telehealth, which I mentioned earlier, does not mean that 100% of our visits are telehealth. It means that 100% of the visits where it's clinically appropriate and the patient can do it, then we should be doing 100% telehealth. So we need, in order to increase telehealth adoption, it requires change management. It's a change management mindset. And I've come across this really great tool at the Mayo Clinic over 20 years ago called the ADCOM model. And I really like it for a variety of reasons. First, it's simple. And second, it explains a lot of the emotions and reactions that you see. So in order to accomplish change, we need to first raise awareness. Why are we doing this? Why are we investing in telehealth? And the desire that somebody actually wants to do telehealth. Then we need to provide the right knowledge, and we need to provide the ability. During COVID, nobody could claim that they were not aware when we needed to do telehealth, and everybody basically had the desire because they didn't want to get sick or they didn't want to accidentally make somebody else sick. So the awareness and desire was there. We're missing the boat was with knowledge and ability, because it was basically, here's a Zoom lesson and a webcam, do telehealth, it works. And unfortunately, it didn't in a lot of cases because patients were not really prepared. The fifth element of the ADCOM model, and that's the acronym here, ADKAR, is reinforcement. Just like in any good management, right? People will go back to the old ways because that's what they're comfortable with. And so for change really to stick, for change to be sustainable, you need to provide reinforcement, which means you measure performance and you just make sure that people are not going back to doing it the old way, or if they do, then that they have a good reason. So these 5 elements, when they're in place, then you have great change. If awareness is missing, then you get confusion. Confusion is like, why are we doing this? I thought it was not being reimbursed anymore, or reimbursed at a lower rate. So all kinds of questions come up. If there's no desire, then yeah, you get flat out resistance. And that's why I said you need to have clinical leadership engaged and saying, no, we are doing telehealth because it's important for our patients, it's important for our financial bottom line, and it's the future of healthcare delivery. And so we better get good at it if we want to stay in business. Or if you want to keep your job, you will do and offer telehealth, right? So clinical leadership is important to create that desire. Knowledge, without knowledge, people are reluctant if they don't really know where to go, how to do things. And if they don't have the ability, then there's frustration, right? If the technology does not work, or if it doesn't work and they can't quickly figure out how to make it work, then they're frustrated. And if there's no reinforcement, then there's backsliding. So this is a wonderful model that I have on my wall all the time, and it applies to anything, not just telehealth. If you are ever managing any kind of change in your own life, with your family, or with anybody in business, right? This is a great model to think about. Have I created awareness? Have I created the desire, provided knowledge and ability, and am I after the fact providing reinforcement? So this is a very good, simple model to look at. So what do we need then to do to optimize virtual visits? And I'm focusing now on like video visits because that's the predominant modality. We need to really engage clinical and executive leadership and create a virtual care strategy. That answers the questions of awareness and desire. We need to define and train on all workflows, and I'll bring up the 7 workflows that we're tracking here in a minute. We need to provide engaging training for the clinicians, for the nurses, for the staff, for everybody needs to know what is the process, what are the protocols, and we need to establish responsive support, right? A clinician doesn't have very low patience for not getting the support they need in order to do it. And so we got to be responsive in that. And then providing the reinforcement is a telehealth performance management system. And so that's what I'll be covering here in the remainder of the questions. Good. All right, some link, just looking at the chat here, slides will be available, and as well as the recording. And then also I have a lot of articles that I've written on these topics, so feel free to visit my website. I've got a link coming up here in the Q&A section. Good. So let me introduce you to my favorite 7 dwarfs, the telehealth workflows. At the core is the telehealth visit, obviously, pretty straightforward, actually, once the patient is in a waiting room and you launch the visit. There's telehealth scheduling, again, which is a little bit different than regular scheduling because you have to look at different aspects as to where the patient is located, where the clinician is located. Most organizations are pretty good or semi-good with the telehealth follow-up, kind of what happens after the visit, and then there's telehealth billing. Where a lot of telehealth is not well defined, a lot of video visits processes are not well defined, is in the rooming process, right? That's different organizations have come up with different ways. There's telephonic. I mean, the ideal scenario would be the patient is in a waiting room. There's a nurse that comes on the screen, takes your vital signs, or if you have some, or just ask you your questions about your chief complaint, any medication changes, anything you want to talk with the doctor about, right? Our normal rooming process. And then they get back in the waiting room, and then the clinician comes in, right? That technology exists in multiple different ways. You can use it in Zoom, you can use it in Doxy.me, in Ment, there's all in some of the EHR providers. So, but it's a matter of workflow and training on how to actually get a nurse kind of into that same room as the provider. And that requires a little bit more creativity. The other biggest breakdown that I've seen is in the actual telehealth post-visit. What happens in the minute after the visit is done, right? Is there a follow-up with the prescription, with a referral, with the next appointment? So that's, I've seen that over and over again, that people don't really have that process well defined. In the old times, right, patient walked out of the room and they had to stop by the front office to have the post-visit experience. But we're not designing for that in our current telehealth environment in many organizations. And so that's an opportunity for improvement to make telehealth as equivalent as an in-person visit. And then the last item here is the telehealth onboarding. What I mean by that, it's if a patient is doing telehealth for the first time, or if you have a new patient that needs to be established, there's a whole set of processes because they're not coming into the office to fill out paper forms. You have to recreate that process finally in the digital world and to onboard this new patient. And so here are the 7 workflows that you should have defined for your primary care practice, your behavioral health practice, your physical therapy practice. So they can be very simple, 3, 5 steps, or they can be more complex depending on your organization. And the starting point is always, what are we offering as an experience in an in-person environment? All right, I mentioned training for telehealth clinicians multiple times. I like this mindset here from Winston Churchill here in WC. I'm always ready to learn, although I don't always like being taught. So keeping that in mind, their first trainings are telehealth awareness training. That just means, why are we doing this? Then the workflow training. Again, if the workflow is optimized, it's really just about the telehealth visit, because there's a rooming process that a nurse takes care of. There's a post-visit process that somebody else takes care of. So for the clinician themselves to do the video visit is very simple. Okay, here's how you can share a screen. Here's how you can website manners training. What I mean by that is, how do you create a strong virtual presence? And I have a slide on that here coming up. And then the virtual exam training as well. How do you conduct a virtual exam, right? Testing your sinuses, or you have an abdominal exam, or right. So there's ways to do it. Now, it's not as good as, right, you can't really feel the thyroid here or anything. But right, is it the side of a grape, or is it flat, right? So there's ways to do it that clinicians can walk you through. And it can be documented, and it may not be the equivalent, but it's better than nothing at all, than just having a conversation. And here are the time allocations that we have experienced in doing that. So it's about 30 minutes for that initial awareness workflow and technology training. Pretty straightforward. It's about 20 minutes for the website manners training. A virtual exam training. So really, you're getting here at less than 90 minutes of an investment. You can do it over 3 sessions, integrated into your weekly meetings, and everybody's kind of trained or oriented, at least, on how to do telehealth well. And that takes away that resistance of not having the knowledge on where to find it and how to do it. Website manners here. I'm looking at the time. I think I'm still pretty good, but I said it takes 20 minutes. I can do it in 2 minutes here. Right. First off, in the beginning, you need to make eye contact for 30 seconds. That's what I'm doing. Right. I'm staring at the camera. I'm not staring at Aislinn and Mariah here. I'm looking at the camera to establish contact with you. Right. I don't have to acknowledge my background. I've got my virtual background on. There's no noises in my background. In the beginning, we trained people that, well, that's new to me. It's probably new for you as well, right? But the benefit is, hey, you didn't have to come in. We didn't have to wear a mask. We can actually see each other, right? So, and then ensuring the patient's comfort and privacy. Is there anybody else in the room? Is there anything else that I need to know about, right? Are you in a safe, secure environment? Especially when you're doing behavioral health, right? Can we be overheard? Maybe you put on your headphones or things of that nature. And then the clinician setup, you need to have a professional background, you need to have a good camera position, and obviously no lighting in the background, otherwise you're part of the witness protection program. And then also, as I explained at the beginning, if I'm looking elsewhere, I'm looking at my slides here, and I'm not now looking at the camera with the pictures. So just explaining, okay, when I'm looking, I'm not ignoring you, I'm just entering some notes in the medical record, right? So good clinicians do that as part of their spiel when they're starting a telehealth visit. And then body language, right? You can lean in, you can use your hands, you can lean back, you can make a point, and you can talk, right? You can use all these things. Again, 20 minutes or even 10 minutes, and it'll does wonders for clinicians to feel more comfortable with doing that. We rolled out this training on March 20th, 2020, and that was a Friday. And many people remember that week, what that was like, the beginning of COVID. And the kind of 10, 12 physicians that signed up for it, where we were rolling out primary care and an FQHC, they had a great experience with telehealth in the following weeks. Those who didn't sign up had very bad experiences. We did some physician satisfaction surveys afterwards, and so this really works. And it's just providing the knowledge, and it's not rocket science, but putting it all together is what helps. And yeah, periodic eye contact. Good. All right, we're getting here close to the Q&A. Feel free to tee up your questions. Feel free to just unmute yourself. As Aislinn said, this is informal here. And thanks for those who being and staying on video. 100% telehealth mindset. That is really one of the key takeaways I want you to look at, right? It's really shifting how we think about telehealth. What does 100% telehealth mean for, let's say, your organization? It's when the patient wants it and it's clinically appropriate and the patient has the technical capability, we should be doing telehealth 100% of the time. If the patient wants it and it has the technical capability, but it's not clinically appropriate, obviously we shouldn't be doing it because then it would be inappropriate care. If it's clinically appropriate, and the patient has the technical capability, but it really doesn't want it, then it's customer disservice. If the patient wants it and it's clinically appropriate, then we have the COVID scenario, then it's a frustrating experience, right? If the technical capability is not there, connectivity or how to get the link to work or, right, how to update your Zoom client or all the other things. But if we have all three elements in place, then that's when we should be doing that. And that's how we make telehealth sustainable, right? It's because then we see it's a clinical tool that I, as a provider, can use when it's appropriate for the patient, rather than having them drive in 45 minutes for just a 5-minute conversation or a 7-minute or even 12-minute. Let's do our next visit via telehealth. That's if I'm seeing you on a monthly basis to manage your chronic care, why don't I just have you come in maybe 3 times, 4 times a year? Right? Maybe you can work with a regional clinic to get your vital signs taken, and we can take that. Or I give you a blood pressure cuff, right? So there's so many different ways, especially if we're no longer constrained by a fee-for-service mindset, but really look at what is the best tools out there. Good. And I talked about the telehealth tech check, and then I get some questions here. That's really great. Let me just bring this all up here, or I'll bring it up at a time. This is the checklist where we're training telehealth tech check coordinators on calling a patient, ideally a day or 2 before the visit, saying, hey, Ms. Taylor, you have a visit here with Dr. Getch here in a few days, and so I would like to just run a few things. Do you have 10 minutes? Yeah, okay. Where are you going to be at your visit, right? Are you going to be using an iPhone or a tablet? Do you have good bandwidth connectivity? And when you'll be joining, what's your audio video like? Can I send you a link? Okay, you can click on the link. Okay, oh, now I see you. Nice to meet you. Right? Okay, the camera angle. Yeah, you may not want to put it like this, right? The doctor would like to really see your whole face, right? So it would be nice if you could maybe change the angle a little bit. And the background, right? Maybe you don't sit in front of that bright window and with the lighting. And then also make sure that you can't be overheard. So, right, a quick checklist. It's a quick 10-minute visit. It's a one-time thing for the first time a patient has. That's that telehealth onboarding. And so, again, a very quick way to just get patients pre-roomed, if you will, prepared for a first visit. And then physicians will not get frustrated. And I know 2 years ago, Geisinger, I talked to the telehealth director there, and he said, yeah, I'm putting in 4 personnel requests for telehealth tech check people because our physicians are tired of doing technical troubleshooting. It's not a good use of their time. And that was 2-3 years ago, right before Omicron. And so, yeah, so that's how this works. Good. All right, a few more slides here on strategic sustainability. But let me just take a look at the questions here. Do we manage struggle with patient promise? Technology, great present, curious, verifying clinician outcomes, and FQC RC. Good, thank you. I'll get to that. So here's the guidance for really engaging with executive and clinical leaders. You need to create multidisciplinary governance teams because it involves finance, it involves IT, it involves nursing, it involves schedulings, it involves marketing, right? Everybody in the clinic is involved to make telehealth happen. And so as you are launching processes and projects to improve telehealth, to make it sustainable and a good experience for the clinicians and for the patients and everybody else, you need a multidisciplinary team to govern that, to steer that effort. And they're being directed by, or they develop the telehealth vision, mission, and objectives to raise awareness and create the desire. Then they set the priorities, meaning here's the projects we're going to take on in the next 6 months. And then, as any good leader will do, then you need to allocate resources to those projects and also allocate resources to provide that telehealth support. I'll skip this slide, but I want to talk about the anatomy here of a telehealth strategy. So Most of you are familiar with it, but I brought an example, so that's why I want to go through it. Telehealth vision and mission, the strategic objectives, and then the strategic goals. The objectives are the themes we want to reach. We want to expand our geographic reach. We want to make sure that patients can access telehealth if they want to, and they don't have to go to the competition. We want to make sure that we increase the value we're getting out of our value-based contracts and really provide a great continuity of care and care coordination. And we want to leverage as many as possible virtual care modalities in order to do so. So the leadership team really needs to become aware of why they want telehealth to be used. And so here's just a sample mission and vision from one behavioral health organization. It's to leverage digital health to enhance our responsive, innovative, and collaborative services. So that speaks to the motivation of the clinicians there. And the vision is that they're recognized as an innovator in the delivery of behavioral health care, transforming the care experience through, in this case, digital health solutions. So they expanded the scope, right? So this is the statement that builds awareness and design. Everybody said, wow, okay, we're not just doing it to do telehealth, we're doing it to be seen as an innovator and to make sure that we're doing that. Good. And then the other part, I'm just going to skip because we have some good questions here. But you can see that in the handouts. Well, I'll make the PDF available as well. Just wanted to summarize here visually that you need to have an executive sponsor in the leadership team. You need to have the governance team. You need to provide telehealth support, which can come in the form of operational and technical support. And then if you're launching a lot of telehealth services, also launch support and then the ongoing optimization. That can be the same people, that can be separate people, it can be fractional people, right? So, but these are the different roles of telehealth support that needs to be provided if it is truly important for your organizations to do telehealth well. The day-to-day management, operations, and scheduling is not handled by any central team, but it's handled by the clinical departments, by behavioral health, by primary care. And so that's where that's kind of the org chart of telehealth in your organization. And then you need to also establish the key success metrics, set goals for those, and then measure the current performance and apply corrective action, standard management. But again, I wanted to be comprehensive here in my approach. And then here are the 5 metrics that we recommend you start exploring with. It's the patient and physician satisfaction, which can be measured periodically. We recommend 2-3 snapshots a year. And then the visit volumes and modality, just to get a feel for how much is behavioral health doing with health versus primary care versus specialties, and then making sure you get reimbursement. Good. Apologize for the little rush there at the end, and want to make sure here I get to the questions. How do we manage the struggle with clinical or patient problems with the technology? I think over time, what you can do is you can just, again, the telehealth check, right, the 10-minute call to ascertain whether a patient is really capable of doing so. The other thing is to think about different access points, right? Do you have outlying clinics that are closer for the patient to see their provider or the specialist that is further away? So they can check in and have a telehealth visit there. We're currently looking, for example, in a rural dental clinic of an FQHC that has no other services for patients to use for primary care and behavioral health visits. We're also working on a regional strategy in North Central Washington on establishing access points in libraries as well. So we're working with the library system, and it's going to be provider agnostics. So the other opportunity would be loaner technology, right? Especially in the chronic care management program, enroll them into an RPM program, giving them a tablet that also does video visits. Again, if connectivity is not there, then that is challenging for live video visits. But maybe it can be augmented with at least audio visits and some vital signs that may be better than nothing. So it's really, designing solutions around that. Just curious, are you finding that clinicians are more interested to see the outcomes data related to telehealth, or are they just accepting the telehealth should be a viable option? It depends on whether most people, most physicians that once they understand telehealth and are comfortable doing it are no longer questioning whether this is clinically feasible or viable or not. They're basically saying, this works because I can do virtually or almost everything in a virtual visit than I can do in person. And so And there's studies that have shown that it actually lowers costs because you don't have as many tests or as many other things going on. But I think on overall, it'll just average out. And so that's really where I'm seeing it. And it's the physicians who don't want to do telehealth that are looking for the outcomes data and the proof and the evidence. And yes, we shouldn't offer telehealth. Like there was a study by the EMA comparing, I think, dermatology exams, and they were evaluating how many of those virtual exams were really not up to par, to the standards. And I said, okay, where was the study done on in-person visits, right? So when was the last time you studied the quality of in-person visits, right? Don't just point an arrow at telehealth just because it's new. And so that's the other side. For FQHCs and EMRC, have you encountered any innovative funding models telehealth? Well, it's if you were to replace an in-person visit with a telehealth visit, then that's not a financially sustainable model. But if you are running your clinicians not at capacity, if they're not doing 7 to 12 or not 7, but 10 to 14 visits a day, right? Can you fill those empty availability slots with telehealth visits? Can you convert a no-show or cancellation to a telehealth visits? So that's really, and it's the continued lobbying that this really should be done, should go away. Right, that there should be no reasons why, as an FQHC, you shouldn't be paid the same rate for a video visit than an in-person visit. Actually, you should be paid almost even more because it's a continuity of care issue. Because otherwise, the patient may just not be able to come in because they can't travel. They're the people who can oftentimes have 2 to 3 jobs, single parents, and they have difficulty getting into the clinic, but they can do a telehealth visits, and so you're actually fulfilling the mission of an FQHC. So yes, so I think lobbying. So I don't have any innovative funding models other than really fully leveraging telehealth to fill your existing capacities. Good. Sustainability articles or seminars or appropriate charging the service.
We're gonna launch a quick poll real quick, continuing on, keep going with the Q&A, but if everybody, before you could leave us today, just provide us some feedback on the session. It's very helpful.
All right. Yes, I keep going here. I watch the clock. We've got 3 minutes here before the top of the hour. Again, here the 3x3 recipe, right, that I've provided a lot of information on. And then I wanted to leave you with this telehealth optimization framework, which is what we're doing with a lot of organizations, which you can use as a blueprint in your own organization. And it starts with establish a virtual care strategy, a leadership and a governance team and support. That's the infrastructure. Then really focus on clinician engagement, do a survey, have the clinical leaders really take a temperature check on what is your opinion on telehealth, where do you think it works, where do you think it doesn't work, is it appropriate to your clinic, to your practice, to your patients. Then work on the workflows, on the workflow definitions and policies and the technology, and then provide that training on that. And then back to the leadership team here, provide performance management system, meaning measure the satisfaction, measure the utilization, and provide corrective actions if the actual performance is not in alignment with it. Once you've optimized everything, then you can start advertising it, marketing it externally, but also internally, making it available for clinicians. So with that, I thank you so very much for the opportunity to share these thoughts with you. I'm a true believer in telehealth being here to stay, and it'll grow, and digital health is what we're really moving into. I hope this was helpful and pragmatic. Feel free to reach out to me or look at my website, my newsletter. I've got 200 articles. A lot of these topics were covered and came out of these articles, so you can read up more in depth. They're all available on our website as well. Also have a LinkedIn newsletter. So thank you, Aislinn and Mariah, for some good support here. With that, I wish everybody a wonderful afternoon.
Thank you so much. Real quick, we just have a few announcements from CTRC, but thank you so much, Christian. There were so many great considerations. It was like a rapid fire, fast course of like so many things with telehealth, from change management to like the definitions, models of sustainability, website manner, so many good things. I know you have a ton of resources to go deeper into those topics. CTRC does too, so please check both of us out. Definitely follow Christian on LinkedIn. Our next session, please join us in September. We're actually going to do a Wednesday instead of a Tuesday, switching it up from our usual pace. But join us. We're going to be talking about competency models, differences between and gaps from provider experiences and provider literature, how to fill that gap. So join us. It'll be a great session. It's on I shared a link, I believe, to our event calendar in the chat. So check us out there. Also want to share, we have another opportunity available right now as you guys are learning and just evaluating maybe where your current program is, whether you're getting started or expanding. Do an assessment with us. We have an assessment now, an organizational readiness assessment. We are offering right now the first 15 who complete it will get a report with some feedback and recommendations from CTRC at no cost. So please, if you're curious what your current state is and want to assess, then do it with us. And that's from us. But thank you to everyone who joined us. And thank you so, so much to Christian for sharing so much about us. And I see Mike. Yes, we will. Thank you, Mike. Great suggestion. But this was a great session. We had lots of fun today. So thank you.
Great. Bye, everybody.
Okay.